Good morning. Thanks to the committee for inviting me and for all of you to give up precious sleep and breakfast to be here. I really appreciate it. I've been at the University of Pennsylvania for the last 7 years. Where's my... Okay, we have 20 minutes? Okay. I've been at the University of Pennsylvania for the last 7 years, and it's the oldest medical school in the U.S. From 1760. And some things have not changed yet. How do I forward this? Oh, here it is. Sorry. If you look at the pregnant obese patients, the pre-pregnancy obesity trends have been increasing. This is not just an American problem. There's data from Sweden, which we think of as a very healthy, Scandinavian country. US, of course, is the other end of the spectrum. 3,480 morbidly obese patients, looking at, BMI of over 40 among 100,000 patients. And US pregnancy rates, I'm going to show you what I think is an interesting graphic depiction of that. Obesity and women's health, no matter how you look at it, has multiple negative impacts. You have increases of diabetes, coronary artery disease. You have higher risk of low back pain, osteoarthritis. Contraception and fertility are both negatively impacted by obesity. High rates of gestational diabetes, high rates of hypertension, increased risk of neonatal mortality and neonatal malformations. Unfortunately, socially, there's a decreased intention to breastfeed, decreased initiation of breastfeeding, and decreased duration of breastfeeding. Higher association with depression and multiple cancers. This is the recommended body weight in patients depending on their starting BMI due to pregnancy, and usually our problem is these are exceeded. Pre-pregnancy BMI, gestational weight gain, and likelihood of major depression during pregnancy. Strong correlation. You have a morbidly obese pregnant woman, there's a high probability you'll have major depressive disorders. And this is a continuum. The more obese, the higher the BMI, the higher the incidence. Gestational weight gain is the factor that modifies it. Depending on, it's within and above the Institute of Medicine recommendations or much less. All women with weight gains below Institute of Medicine recommendations have elevated odds of depression. Increasing prevalence of hypertensive disorders among delivery hospitalizations between 1988 and 2006. They went from 67 per thousand to 81 per thousand deliveries. Preeclampsia, acute renal failure, DIC, intubations, pulmonary edema, puerperal cerebrovascular disorders, as well as respiratory depressive problems. Hospitalizations with hypertensive disorders, 57% associated with acute renal failure, 27% with disseminated intravascular coagulation, 20% with ventilation and intubations, and pulmonary edema and RDS. How about even vitamin D? When you look at pre-pregnancy obesity, it's a risk factor for vitamin D deficiency. Compared with lean women, pre-gravid obese women had a lower serum vitamin D concentration and a higher prevalence of deficiency. Problem goes on to the baby. The vitamin D status of neonates born to obese mothers are poorer than to lean mothers. And dose response curve between pre-pregnancy BMI and vitamin D deficiency is a continuum. Now, when we look at unfortunately, the US is a shining beacon of something that they should not be, and which is we're leading the way in obesity. And the CDC, the Centers for Disease Control in Atlanta, actually has decent data in the last few years. They started collecting this data in 2005. And right now, only one state has less than 20% obese patients. And this is a depressive statistic. This is the 1985 data. The white states of the 50 states, they have no data at this point. And as you can see, the light blue, darker blue, the darkest blue, the yellow, orange, red, and red is the percent who are a certain percentage of obesity. I'm going to flip through this very quickly just for you to make the impact. So this is 86, 87, 88, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 2000, 2001, 2002, 2003, 4, 5, 6, 7, 2008 and 2009. This is depressing. This is the fattening of America. Supersize me. The obvious implications of this is when you have an obese population, a morbidly obese population, is you're going to have morbidly obese pregnant patients, and you're going to have all the complications associated with obesity and pregnancy. So, how do you approach these patients as the anesthesiologist? We don't see the patient through the pregnancy. We may see them a day, sometimes an hour, sometimes minutes before they are going under our care. You want a thorough history and exam if possible, and you want to examine their back and you want to examine their airway, because we don't know where we'll have to approach them in terms of providing an anesthetic. You want to get adequate IV access. We talked about this yesterday briefly also. Fortunately, most pregnant women have nicely vasodilated and they have veins sticking out everywhere. If necessary, put a central line. And the morbidly obese or the supermorbidly obese may have problems with peripheral access because their hands swell up and the veins get lost. When do you want to put the epidural? Now, usually in most countries, the epidural is placed by sensation, palpation. But when you cannot palpate anything, what do? How about ultrasound? Of course, unless you're a frequent ultrasound user, you're a regional anesthesia person, and you have the equipment, that's nice. But what if you don't? Your obstetric colleagues have ultrasound probes. Use them. That will give you an estimate of the distance, the depth at which your epidural space lies, and it might help you spot the anatomical place where you want to inject the needle. Now, there are three possible airway scenarios: bad, worse, and rarely they can be good. And you could be looking at an airway like this. And this patient has a BMI of, I think, 80. And you can see what her airway is looking like. He has another one, BMI of 71, BMI of 70. You can see I deal with the supermorbidly obese. I mean, this is the airway you will face. So what do you want to do? You want to promptly look at their back and see if you can get an epidural in. That saves the day. Sometimes they will fool you. When they open their mouth, you see a class 1 airway. Obesity directly does not predict difficult intubation. The two predictors of difficult intubation are Mallampati class and neck circumference. The larger the neck gets, the harder intubation gets. Everything else is speculative, has not really been established, has not been statistically borne out to be a higher predictor of difficult intubations. As far as intubations go, the general figure is 10% of the morbidly obese are difficult to ventilate. 1% are difficult to intubate. Difficult. It's not impossible, it's difficult. And I'll show you our approaches. We've had fairly good success. I do a lot of the bariatric cases, so I deal with patients who have gone as high as BMI of 110 and a real weight of over 700 pounds, almost 800 pounds, 790 pounds. That's what, about 350 kilos or more. So I'll tell you how we've had, and in the last 6 years, 7 years that I've been doing this at UPenn, I'm not superstitious, but knock on wood, we've had no case of could not intubate, could not ventilate. And I'm talking about morbidly obese, supermorbidly obese, average BMI is 51 in the bariatric OR. Why is that? Only 5 of us out of 76 will do these cases. We have a consistent approach to the airway. I'll show you mine. Now, back anatomy, what about the challenge? What do you want? You want to bring large needles, you want to bring some experience, you want to bring patience, and it never hurts to bring some luck. But you make your own luck. The harder I work, the luckier I get. I don't know how that happens. You realize that the option is to go to a general. And that is why, as an obstetric anesthesia group, we become very good at approaching the back. But when the back fails us, or the patient says, I don't want a needle in my back, I've heard it gives you back pain forever, or it's going to paralyze me, and you're forced to go to the general anesthetic option in a morbidly obese patient, that should and does increase our own sphincter tone. You really don't want to try and intubate these patients unless you have to, especially the class 4 airways. Many times in obstetric ORs, you're working by yourself. Somehow what starts at night seems to finish at night. These kids are born at night, which means you have no backup. Now, when you're in the main OR, you've got colleagues left, right, and center, and I'd say, Sunanda, come hang out in my room. I've got a case that I might need a hand with. At 3 a.m., that's not an option. It's me and the patient, and the obstetrician screaming, fetal heart sounds are down. I've got a non-reassuring fetal strip. We need to go to section now. Realize that the obstetrician's interest is in the baby almost more than in the mother. Your interest, legally, medically, socially, however you look at it, is in the mother. I'm sorry, if you have to make a choice, you have to save the mother. Here's the back you're looking at. Now the question is, what are you going to do with a back like this? Is there a laser pointer here? Can I get a laser pointer, please? It's on this? Oh, yeah. I'm good, thank you. So this is the back, and you have an idea that this patient has definitely moved the skin away from the epidural space. Question is how much? Now, this patient is actually easy. You know why? She's given you a target. It's right here. This is where the skin is closest to the epidural space. You can always thread your catheter up. Now, here's another one. I'm sorry, I know these pictures are embarrassing, but just don't use your camera phone and take it anywhere with you. So, you've got rolls upon rolls upon. Now, I thought in the front they are called panis. I don't know what they're called in the back. I don't think we've come with a term for it yet. But here's your target. Here, maybe here. But you need the large needles. Your normal epidural needle is 4 inches. You want the 6-inch epidural needle. Here's another back. There's another back. Now, the part of the problem is, when you're looking at this back, you can't even tell midline. Let me show you one. Where do you think the midline is? You can see the maceration, but this probably is the midline. But if there's any scoliosis, you can't feel it. What I think can you actually palpate in these patients? And I hope I have the right picture to show it to you. My residents really get happy when they put in epidurals in patients who are that big. And here we are. Now, this is too low. This is probably too high for what I want. And this is probably an X centimeter, X inches away from the epidural space. Two problems. When you have a patient who is, say, BMI of 30, 25, 30, normal patient, the distance from the epidural space to the skin would be maybe this much. 4, 5, 6 centimeters, you'll get lots of resistance. And you thread the catheter in 5, 6, 7 centimeters. When this patient moves and rolls, the back skin will move so much, it'll pull itself out of the epidural space a centimeter or two. And the distance is this much. Even if you got the tip in the space, when this patient rolls, the catheter is coming out of the space. So all your beautiful work is to not, as soon as it transfer the patient onto the OR table and the catheter gets pulled out of the epidural space. So how do you get around that? Bury the catheter till the last mark. I don't care if it's 12 centimeters in the space. It will come out as the patient moves, but you still need an effective 4, 5 centimeter catheter depth in the epidural space. So this is the trick that I have developed. I take those back pani away, just like surgeons will sometimes do, and we will do when you're doing a central line in a patient with a large breast. You have to just take it out of your field. And I found that really helped. We were actually able to, and you can see the tape holding the panis out of the way, and my resident is able to thread the catheter in a patient who was, I think her BMI is 84. All right. Some obstetric anesthesia practices have become completely dependent on the ultrasound. Mount Sinai Hospital in Toronto's direct code, never do it without an ultrasound. They use ultrasound to measure the epidural space distance before they put the needle in. It's very nice to know how deep you can go before you have to start worrying about the space. But otherwise you're experimenting, and somewhere you have this layer of fat where you think you got loss of resistance, but either it's not deep enough or you're not quite sure. But by the time you do the test dose and you wait, if you tape it and let this patient lay down, if it doesn't work, it doesn't work. If you can use an ultrasound and get a feeling that, okay, it's 7 centimeters, I'm right around 7, this should be where it should be, then we'll be fine. How about estimating this distance based on height and weight? The McGee Women's Hospital, University of Pittsburgh Medical Center, there's a Pearson correlation coefficient which is more than 0.85. What is the drawback? It works very well in normal height and weight patient. As soon as you become morbidly obese, the coefficient drops to 0.59, which means it's a great system until you really need it. So, but when you combine ultrasound, and they found that they had no dural punctures in 56 patients, which is fairly impressive. This is a patient that we really had a problem with, and my resident actually tried to put this epidural, and then I stepped up, and in all honesty, I got lucky, and this is what her back looked like. What is the failure rate? In morbidly obese parturient with a BMI over 40, about 5% failure rate, means 1 in 20 of your patient will not have a functioning epidural, just when you're getting ready to go to C-section. So what are you going to do? The general anesthetic. Turn to plan B. A couple of quotes here. Make haste slowly. You don't get good by being fast. You become fast by being good. Have you watched a good cardiac surgeon operate? No wasted motion. No wasted motion. And they're very fast. They're not scrambling. They're never trying to do some things. So what are you going to do with your airway? You've got multiple options. You got direct laryngoscopy. You got a video laryngoscopy. You got awake intubation. You got fiber optics, you got air tracks. There are multiple ways of doing this. What is your comfort level? What is the tool you're most? If it's an intubating LMA, so be it. You have to stay within your comfort zone. This is not a time to test, to learn, to experiment. That's on your normal patients. So what we do here is, this is the same patient I did the epidural on. We put her down on the OR table. You want a position of this patient where the external auditory meatus is in line with the sternal notch. And I'll show you that once we got her position. So if you look here, we approximately got these two lined up. And I have essentially got a 30% head up, a 30-degree head up in this patient. What I want to show you is this is not, you don't have to have an inflatable, reusable pillow. What you really need is to get this angle. We've done with the blankets. You can see we can do the same thing with blankets. And this is not for her modesty. The reason I'm using this is once this patient is anesthetized, if you tug at those two corners, all of these fall down. For want of a better word, I don't want to put one blanket out of the other over dead asleep patient because they're a dead weight. And now you see, using blankets, we've got the same position. The external auditory meatus in line with the sternal notch. Back to this first patient, I'm going to show you how we induced. This is the one who had a class 1 airway, so I allowed my resident to do a direct laryngoscopy. Her BMI is 91. So what we did was we put this pressure support breathing. This is just like her CPAP mask at home. And we oxygenated her thoroughly. We waited patiently. Now here goes the succinylcholine and propofol, which is my combination, unless there's a contraindication, which would be rare, egg allergy or something. You have multiple reasons why you wouldn't use succinylcholine.
So another 2 minutes for you, sir.
I'll be done. Cricoid pressure, I'm a big believer in that. And what I like to do is as soon as the patient is induced, I will stick a nasal trumpet or a nasal airway. And the idea is if I were to get to the point where I cannot get a tube in, I know that I can at least deliver oxygen to the oropharynx before the tongue collapses back and totally locks me out. So we go down. And the one of the things I want to point out is my resident is standing on a stool here to get the height. But when she looks down, she's going to find the vocal cords here. Normally you're looking in this slide, not here. Now you're looking straight down, and watch this. Tube, DL, look at the line of sight, straight down. And that's why she's looking. So if you extrapolate that, here are the cords, she's looking straight down, tube goes in, direct laryngoscopy, MAC4 blade, we're done. Tube's in, and of course now we are looking for our good friend, the end-tidal CO2. Continuing to hold cricoid pressure. So here is one approach. Here's the second approach, using an entry intubation catheter. This is a blue catheter that actually, and this is a bronch adapter. that your pulmonary surgeons will use to do to do a bronchoscopy. And this goes onto the entry catheter, and that goes onto your fiber optic. It's just a little shorter than the fiber optic. Pre-oxygenate the patient, succinylcholine propofol, holding the mask in place, crack out pressure. You put an LMA in. All of us are familiar with the LMA. Once you put an LMA in, you've got CO2, you've got a good saturation, and you have time now. Now you can breathe. Here goes the fiber optic, entry loaded on it, bronchodapter here. I'm going to put it right through here. The connector comes off, this goes in, and now we're hooked up to the bronchodapter. Now we can oxygenate vocal cords, rings, trust me, and carina. Once I have that, I slide the entry off, and I onto there and pull the fiber optic out. And I've got in the airway an LMA and an entry. Next thing, LMA comes out. I continue to ventilate. You can see I have a good agent on board. I have a 99% sat. My pressures haven't fallen. Now, the LMA is going to come out and the entry is going to stay in the air, but I'm going to have to grab it with these grabbers. I'm going to grab it intraorally. LMA comes out. Endotracheal tube goes on top of the entry, goes in there. Now I'm going to bring my clamp out and put it on top here, grab the entry, advance the endotracheal tube. 30 seconds later, I have my airway, I have my system connected, and my resident is happy. And look at that, 97% sat, blood pressure, heart rate, gas on board. Thank you. Is that good timing?
Yeah, thank you.